Let me thank profusely General Electric and Accenture, who have sponsored this event. We thank them very much. Much appreciated. And we certainly appreciate Jeffrey Simpson being here this morning. Jeffrey, I will not introduce you because everybody knows who you are, but we'll get to you in just a moment. I have a few announcements first. And here it is. Our program to the end of this working year, so that's up until summer, is in May. Alan Bernstein's going to come in. We haven't quite decided what he'll speak about, but you can understand it'll probably relate to research. In June, Helen Angus is coming. I suspect that's going to relate to the linked system. And on May 15th, so keep this date, working with Helen Angus, Barry McClellan, and a whole series of people, we're putting together an all-day conference on health links at Rotman. It's a very good program. May 15th, mark it in your calendars. That's all I have. Thanks for coming. Jeffrey Simpson, you're on.
Thank you very much. I often tell people who are kind enough to introduce me to keep it short, but that is really a record. Several comments by way of thanks. Thank you to Longwoods for inviting me. I'm glad I could be here this morning. And whatever I might say about the Canadian healthcare system, I always talk about the excellence of the acute care hospital portion of the system. They're often asked to do things that they're not as well equipped to do as other parts of the system, but given those constraints, they do a wonderful job. And I've said to every group that I've talked to that if you have a serious problem that needs the attention of an acute care hospital in our system, the chances are overwhelming that you're going to get extremely good care. And nowhere is that truer than in this building and in the cluster of acute care institutions which surround it here in the University Health Networks of Toronto. So it's an honor to be here. And I don't know whether the hospital CEO, Joseph Mappa, is here, but if he isn't, please pass on to him my regards. I had a wonderful day as I was doing my research here at Mount Sinai with some terrific people from the hospital and from the Action Canada Network, which brings together a number of really brilliant young people from various disciplines, and they have a number of folks who are in the healthcare system across the country, and some of them came to Toronto to talk to me and help me understand better. And then I went and saw CEO Mappa on his own, and he's an arresting character, as I think you all know. So those two thank yous. I just came back last night. This is a bit of a ramble by way of an introduction from Germany, which is a country that I visit often and I try to understand well. And I'm always interested when I'm in Germany, and impressed, I might say, by this. All societies and all countries have narratives about themselves. Some of these narratives are deeply disquieting, as in the case of Germany, and it's to the immense credit of the last few generations of Germans that they remember in a very direct and public way the ghastly narratives of the last century in which they figured so prominently. Now they have a narrative about themselves, a whole other subject having to do with the economic crisis in Europe and the role that Germany is playing. And generally speaking, the narrative is that the Germans 10 years ago took some very difficult economic medicine and turned themselves from what was described in those years as the sick man of Europe to now the powerhouse of Europe, and that same diagnosis, to use a medical term, and the remedy for the diagnosis should be applied to the other European countries, and that they should go through what the Germans went through. So there's a kind of moral virtue in Germany at the moment. That's the narrative they tell themselves. And I was thinking about that in the context of Canada. We tell ourselves narratives, and one of the longest narratives we've had, it's 50 years old now, and certainly one of the most self-comforting narratives until recently was that we had the best healthcare system in the world. This narrative was reinforced repeatedly by endless politicians, whom I covered in all political parties and at both levels of government. It figured prominently in the Romano Commission of 2002, in which it was said, and I'm paraphrasing but closely, that the Canadian system compares favorably, those were the verbs and words, with the other largely public healthcare systems in the world. It was repeated by Commissioner Romano countless times after his report. It was repeated by what I call the Romano School, the academics and the health policy experts who had dominated debate in this country for so long and who had done all of the research for his commission, some of whom are still alive and pesky today. And it was a narrative that Canadians desperately, and that's the wrong adverb, very much wanted to absorb. One of the ironies, not ironies, but one of the interesting elements of our country, and you know this, is that when the pollsters ask Canadians what is the most important national symbol for English-speaking Canadians, they don't say even the Charter of Rights and Freedoms or Parliament or bilingualism or multiculturalism or the RCMP or hockey or, God forbid, the monarchy, which I'm glad to say as an anti-monarchist is at the very bottom. They say healthcare. And we're the only country in the world that holds healthcare up as a national symbol. So if what you describe as your most important national symbol, you're constantly being told is the best in the world, it kind of puffs you up a little bit. And it also served the dual purpose of puffing up our moral superiority vis-a-vis the United States, which is a deeply ingrained habit in the Canadian way of thinking about ourselves. Now, in Quebec, it isn't that way. Parce qu'au Québec, ils ont la langue et la culture française qui représentent la définition, l'existentialisme du Québec. Ils n'ont pas besoin d'un système de santé pour se définir. They don't need the healthcare system to define themselves. But we and the rest of the country did. So this narrative that we were the best was appreciated. It was easy for anybody to say, political people. Nobody would stand up and object. It was a vote seeker. And as a consequence, most political debate around this issue over a long period of time featured one political party versus another, didn't matter which jurisdiction, and it didn't matter whether it was federal or provincial, promising to spend more than the other party on this sacred trust, which is the Canadian healthcare system. And that's kind of where I came in and said, you know, I think instinctively that narrative isn't right. I don't think the antidote to the narrative is to start preaching some private system, which I don't believe in. I don't think it's to call for us to adopt the U.S. system, which would be quite wrong to do. But somebody should take a critical look at this kind of myth. And if journalists and analysts aren't the ones to do that, since nobody else seems to, why not me? So that's what I set out to do. And when I did, I instinctively thought, but then I learned that in fact the narrative was wrong. And the problem with wrong narratives is that you can spend a lot of time chasing the narrative and not being critical enough about the actual institutions or arrangements or assumptions that are around the narrative, and so things don't get any better. If you think that you're the best student, you're the best business in your industry, you're going to delay self-examination because, after all, we are the best. I am the best. You are the best. Why? But I'm going to run through things that most of you know about. And let me just say that somebody trained, however imperfectly, in social science knows that comparisons have their limitations. They ask different questions. They evaluate answers in different ways. They weight matters differently. So no one should rest an analysis on one survey. But as many of you know, the Commonwealth Fund in the United States, in looking at 7 public health care systems, Australia, Canada, Germany, the Netherlands, New Zealand, the UK, and the US, on a range of rankings, you know this, we finished 6th out of 7. And by the way, that's 2010, and in 2008 we ranked 5th, and in 2006 we ranked 5th. So we've gone backwards at the same time as we've been spending more and more money. Another recent Commonwealth study that was released a month ago, some of you may have seen it, was a survey of physicians in 10 countries. And in Canada, there were over, family physicians. In Canada, there were over 2,000 family physicians who responded, which is a very large sample size. And a range of questions were asked around the issue of technology and medicine, particularly so-called high technology. And in every category, we were either 9th or 10th out of 10. And this survey asked questions like, how long does it take to deliver records from a hospital to a family physician? How many family physicians are using e-health? How easy is it for patients to contact their physicians via technology? And so on and so on. They asked about 12 questions. We were 9th or 10th out of 10 in every category. That's not easy to accept. The Euro-Canada group is a barometer that deals with this is a patient satisfaction survey, okay? And it asks 32 questions, and then it assembles the answers and comes up with a ranking. And of the 34 countries that they measured, in terms of patient reaction to the healthcare system, ours came 25th. Below us were Slovakia, Malta, Albania, Poland, Lithuania, Latvia, Romania, and Bulgaria. The OECD goes about this in a different way. They are the classic number crunchers that are relied upon in all the member countries, of which there are 33, in a range of areas. They have a big healthcare analysis section, but they crunch numbers on all kinds of different matters. And of the 33 countries, our life expectancy is 12th, diabetes is 8th, prostate cancer 8th, heart disease 12th. So those are, from an outcomes point of view, defensible outcomes. Infant mortality, however, we're 27th out of 40. Per capita MRIs 19th, CT scans 22nd, hip replacements 21st, knee replacements 11th. Hospital discharge rate out of 37 countries, and I am in a hospital, we're 34th out of 37. Occupancy rate for acute care beds, again, I'm in a hospital, an acute care hospital. Occupancy rate 29th out of 30th. So we've been talking now for some years about the need to move patients away from acute care hospitals into other less costly and often more appropriate settings, one of which would be long-term care facilities. Well, we're below the OECD average by quite a bit in that. We're below the OECD average in what, as a share of total healthcare spending, we spend on long-term care facilities. Drug costs and physicians' pay are way above the OECD average. So the OECD, in summarizing the Canadian system, said that we have above-average overall costs, a point I'll come to in a moment, average healthcare outcomes, less high-tech equipment, fewer doctors and medical students per capita, less choice among providers and patients, less regulation on prices for everything outside Medicare, long wait times at every level, weak setting of priorities by the payer, namely the government. Now, the flip side of this coin, as you all know, is that we are in the top 5 as a share of our national wealth that we spend on healthcare, which is no problem. I've never criticized that, because all rich countries spend more than poor countries do on healthcare. And we are a very rich country by any standard, including within the OECD. And economists would call healthcare, it's kind of a strange phrase, but they call it a luxury good. So rich countries will spend more of their GNP on healthcare than countries that have less to spend. But within the top 5, where we sit, along with Germany and Denmark and France and Switzerland and ourselves, we're spending 11.76% of our GNP on healthcare. By the way, the states I just exclude from all of this because they're in a league by themselves. They spend 17.5% of their GNP on healthcare, and their healthcare outcomes are not 50% better than ours or anybody else's, which is what you'd expect on a value for money proposition, and nobody in the world wants their system except themselves. In fact, they don't want their system anymore, and that's why the bomber is going to change it. So the problem isn't we're spending a lot. The problem is that the other countries in the top 5, when you go through these surveys of outcomes and patient satisfaction and wait times and all this, they stay in the top 5. We're the only country that's in the top 5 from a spending point of view, but is nowhere near the top 5 when it comes to all these other indicators. And that's the value for money proposition that completely gives the lie to the narrative that we have the best healthcare system in the world. Because we don't, by any international standard. Now, in this province, just to give you a couple of numbers, when I talk about spending, when the McGuinty government was elected in 2004, the Minister of Health in that year was Greg Sorbara. And of course, they got elected because people were unhappy with the previous Harris-Eves crowd. And one of the big knocks on the Harris-Eves crowd by the incoming Liberals, I'm not here to defend any political party, I hasten to add, was that they'd starved all public services, including the healthcare system. Actually wrong. The Harris-Eves crowd had what was called the Fair Share Health Levy, paid by all citizens who earn more than $75,000. They were seen as big tax cutters, Harris Eves, but they actually weren't if you were including the fair share health levy of over $75,000. And health care went up under the Harris Eve government by somewhere in the range to 5 to 6% a year. Anyway, in come the Liberals, and Greg Sorbara takes over, and in his first budget, he announces an increase to 7% a year for health care. But he says in that budget that that level of spending is, and these are his words, not mine, unsustainable. Every budget from 2004 until 2011, the increase in healthcare spending was 7%. The very number that in the first budget the minister had said was unsustainable. So either he didn't know what he was talking about, he didn't mean it, or he meant it, but he got overwhelmed by the cost drivers in the system and by public demands. Now this year, this fiscal year, the government of Ontario is trying something totally revolutionary. Never happened in the history of healthcare since Medicare came into force in 1972. They're trying to restrict the increase to 2%, as every hospital and physician knows. In Alberta, the budget that came into being last week, they are going to try to restrict the increase to 3%. In Alberta, for 10 previous years, the healthcare budget went up every year by 9.5%. Yes, there was population growth in Alberta. Yes, there was inflation that all of us have to build into our calculations. But still, the healthcare budget in Alberta rose by twice as much as inflation and population growth each year for 10 years. So now, from 9.5, they're trying to bring their health budget down to 3. And their budget provincially is now 45% health care. Next door in Quebec, and this has been going on for the longest time, health care is still going up at 5%. General government revenues are going up by 1.9%. You don't need a degree in advanced mathematics to know that all the other programs of the government in Quebec are being cut. And you will have read, perhaps, in the last 2 weeks, un grand sommet sur l'éducation postsecondaire, big show in Quebec City. And big tranches are now being taken out of the university budgets in Quebec. Big tranches are being taken out in Alberta. And I'm on the board of the University of Ottawa, and we are waiting daily for what I think is going to be grim news from Queen's Park about our budget for this year and the fees. So you can see in the trade-offs, even when the healthcare budgets are brought down, as they have been, other areas of government are having to give way. So the operative question to ask, and the answer is too soon to tell, is are we going to see, because nationally healthcare spending in the last 2 years is down to 3 to 3.5%, as opposed to 6 and 7% for the previous decade. Is this something that is reasonably temporary? That is to say, 3-4 years. Because we've seen this before, that healthcare spending goes down for a while, and then there's a big surge afterwards. So are we simply seeing a repetition of what we have seen before on 2 or 3 occasions, or are we baking into the system something that is more structural and therefore more sustainable? Now, lest I be too critical and pessimistic, I think there are actually at the moment a few hopeful signs. I'm actually guardedly more optimistic about matters than I was a couple of years ago, let alone when the book came out last fall. And I'll give you a few reasons why. The existential nature of healthcare for English-speaking Canadians continues. But there is a new realism, I believe, that is at least in what I would call the civic society parts of our population, civic leadership, and particularly in the healthcare field, I observe, a new realism. Recently, the Environics Institute, which is a group for whom I have a high regard, published their Focus Canada survey, which they've been doing since 1976, so there's a lot of longitudinal comparative analysis that you can do. And in 2002, so roughly a decade ago, when Focus Canada asked the question of the respondents, what was the main cause of the problems in the healthcare system, at that time, 44% of the respondents said that it was a lack of adequate funds. Today, that figure is 26%. In 2002, 41% blamed inefficient management, and now it's 62%. So, from roughly an equal number a decade ago who said funding and management, you've now got about 2.5 to 1 that says the problem is management and not funding. I think that is a correct analysis on the part of the population. Having said that, please read this number in the following way. I've been around public policy for a long time, too long, many critics would say, but it's what I call the dream of efficiency, and it applies not just in healthcare, but in all areas of public life. If you put to the public, or people who work in public institutions, that you have a revenue problem, or you have a funding problem, or you have a budgetary problem of some kind or other, the instinctive answer of people is make the system or make the government more efficient. Don't raise my taxes, don't take anything away from me, make the system more efficient. So leave health care out of it. That is the instinctive answer of people all the time, which is why politicians, when they want to try to deal with a fiscal problem, the first thing they do is they freeze their own salaries, they freeze the civil service salaries, they cut the number of civil servants. You watch the budget this Thursday. I guarantee it, as sure as we're all in this room, Mr. Flaherty is going to take a couple more $1 billion out of the budget, in addition to the 5 he took out last time, and it's all going to be dressed up in language like reprofiling, efficiency gains, transformative blah, blah, blah. It happens every time because that's what the polls tell the politicians the people think, that all of these problems can be solved by efficiency gains. So the answer that Environics came up with is the fallback position. And I wouldn't read more into it other than the fact the flip side is that the public, at least for the moment, has come to an understanding, or at least 3/4 of the public, that shoveling more money into this system, well above the rates of inflation, well above nominal GDP, well above the spending in all other areas, is not making the system appreciably better. And I'm encouraged by this because, as I said to you, I covered too many election campaigns that featured one party or the other promising to spend even more than the other fellow did, or woman did. And that produced the vortex of the 7% increases that I don't think got us very far. In fact, the other day, for completely other purposes, I was looking to see what the federal NDP had to say about a few things, not healthcare. But I said I wanted to see what they had to say about healthcare. And I was quite depressed because what they want to do, and it's back to the old politics again, they want to increase the escalator from the federal transfers from Ottawa to the provinces for healthcare from 4%, roughly, where it's going to drop in 2 years, back up to 6%. Well, then you're playing the old game. I'm optimistic because, as I said, at least temporarily, the increases have gone down to 3.3 to 3.5%. Why is that happening? Well, there are a number of factors. I don't pretend to understand them all. Some patent drugs are losing protection. Wage settlements are much more reasonable by physicians and unionized employees. The provinces are all in the fiscal soup, except for Saskatchewan, and the bargaining units get this, at least for the moment. I said, and I stick to it, in chronic condition, that we need to have an understanding, not necessarily an agreement, but an understanding between the physicians and governments that their remuneration will go up at roughly the rate of inflation for the next decade. Because we can't have the huge surge in physicians' incomes that occurred after we started putting huge additional amounts of money into the system, because they and the nurses took a disproportionate amount of the money, which is exactly what any student of public administration could have predicted would happen. Because and this would apply in universities, and this would apply in the education sector, those groups that are the most organized and the best mobilized when you inject a lot more money into a public system are the ones best capable of taking a disproportionate number of the gains. That's an almost ironclad rule of public administration, and it happened again, and it was amazing that a former provincial premier who recommended that we inject so much money into the system didn't see that. It happened as if it was a textbook. I'm a little more encouraged too, because I think there are now political people who are willing to tell the truth, because I've heard them. I've heard the Minister of Ontario, I've heard the Minister of Alberta on public platforms, unprompted, say essentially what I said at the beginning of my remarks. Not because I said it, I hasten to add, but because they are studying the international data. Ms. Matthews has been down to the Commonwealth Fund. You can't look at this data in the face and be honest with yourself and your audiences and stand up and give the old narrative. You're just intellectually dishonest. And this is progress because you have to get the right starting point for a discussion that goes anywhere. And so these ministers, with their constrained budgets, are starting to tell audiences and the public the truth. And that helps and is encouraging. It sends the right signal to people and allows us to have a debate that starts from the correct general premise. Ironically, the same Environics Institute survey found that by a 2-to-1 margin 10 years ago, people thought that the system was in a state of crisis. Today, the numbers are about even. So that's interesting that although they don't think the system is better, and they know a great deal of money's been poured into it, they're not thinking the system is in as much of a state of crisis as they were 10 years ago. Just a couple of other figures from the survey that I found interesting. If Canadians, they were asked, should be given the right to buy private health care, and here's the key, if they don't receive timely access to the public system, by 54 to 43%, respondents said yes. Similarly, the option of paying out of pocket for faster service that was rejected a decade ago by 62 to 36% is now 50-50. The least attractive options, predictably, were raising taxes, 56% were opposed, or cutting back on services, 72%. So policymakers and political actors are in a bit of a box, because if they want more revenues for health care, I don't think they should, but if they do, then higher taxes are opposed by a majority. Income-related user fees, or co-payments as they're called, are also unpopular. A special tax for health, as Quebec discovered, becomes quite politically controversial. And cutting back on services is extremely hard. Delisting things, for example, very hard. I'm optimistic for a final reason. I think more change will come when money is more scarce than when money is munificent. Because the fallback when money is munificent is that money can solve problems. When money isn't so munificent, people in institutions, people who run institutions, people who work in institutions have to be more creative to find better solutions than to count on money dripping into the system. I think, therefore, and I think there's evidence of it already, there's more change happening now, and I think there'll be more change in the next 5 years than there was in the previous 10. And by the way, the factors that are forcing the change, I mean the financial factors, are not going away anytime soon, and I'll just tick them off. First of all, I made mention of the fact that Mr. Harper has already announced that in 2 fiscal years, the percentage increase in the federal transfers will drop from 6% to nominal GDP, which is somewhere in the 3.5% to 4% range. That will have a multi-billion-dollar effect on provincial budgets, as the Parliament Budget Officer, the outgoing one, told us. Secondly, we still are in the long aftermath of the financial recession of 2008. And without taking you through a long fandango about that, financial recessions are the most severe of all kinds of recessions. They generally take at least a decade to work their way through the systems. And as we see in Europe, the devastating effects, we've seen it in the United States. Growth is expected to only be 2% at best. We see it even still in our own country because we're part of the Western community of countries where growth is expected this year to be 1.6%. We're moving, or I should say we have moved into a decade where instead of having an average of 3% growth, the way we did in the 10 years before 2008, we're going to have probably 2% in the decade after. Again, it doesn't sound like much per year, but over 10 years it has a multi-billion-dollar effect. And as a consequence, governments are, to use an economic term, deleveraging. They're trying to reduce their budget deficits and their debt load if they can. And in this province, we're not going to have a balanced budget for, another 3 or 4 years. Of course, there's all kinds of political things that can happen between now and then and other factors. But this is true in every province. Even Alberta is now running a big deficit because, don't get me on the subject of Alberta's fiscal situation, but I mean, the discount in the oil price is causing Alberta to run a big deficit. And we have aging of the population. Now, aging is worth spending just a little bit, a moment on. Aging is, I think, a matter that we are beginning to grapple with in all areas of Canadian life. You can see it in pensions. Only 9% of people who work in the private sector now are covered by defined benefit plans. It's 50% in the public sector. There's a tension coming between those in the private sector who don't have DBs anymore and those in the public sector who are fighting to retain them. But that's a whole other issue. You can see how government or public pension plans, in not all cases, but many cases, are underfunding, requiring a de-indexing of cost of living, more contributions by younger employees, longer times before you receive a pension, etc., etc. In healthcare, of course, we have to work, as provinces are trying, but it's slow to change the system, towards one that pays more attention to the healthcare needs of seniors in non-institutionalized, that is to say, non-hospital settings. Because the bed blocking problem that you know so much about and that I wrote about in the book cannot be dealt with even in part unless there are places for those folks to go and people trained to deal with them in the other places. And so it's too bad we didn't get on this a long time ago. We knew aging was going to happen. It's happening faster than people had predicted even 5 or 10 years ago, but the need is very, very urgent. And Dr. Sinha from this hospital produced a report, a very good report, on the long-term care needs just a few months ago. However, I would just say, you'll think I'm a budget maniac, he said that, and he's right about this, that the spending for long-term care facilities and long-term care systems should go up at 4% a year. Now, again, you don't need an advanced degree in mathematics to know that if your healthcare budget's going up by 2 and you're spending 4 in that sector, something else has to give. And acute care hospitals are big cost drivers in and of themselves, so tell me how you're going to make that circle go into the square, but it's a good discussion to have. It's generally thought by healthcare economists that aging per se will cost the system about 1% a year, and we are then enjoined not to be too worried about it. And I wouldn't be, because we're spending $207 billion a year on healthcare, 70% of which is public, so that's, let's say $145 billion, 1% is $1.5 billion. In a province like Ontario, that would be what, 700 million? Stretched out over time. That's not a budget breaker. But the flip side of the coin is something that's very seldom talked about in healthcare. Because healthcare people, like education people, we're all the same. We look at things in a silo. What's happening in Canadian society, pensions are the classic example, is you're getting the beginning of a profound demographic shift such that there will be fewer people working on whom you can impose taxes at the highest marginal tax rates depending on their income, vis-a-vis people who are out of the workforce and generally earning less, but whose demands, social cost-wise, are higher. And nowhere is that more acute than in healthcare. So the costs for aging in the healthcare system go up. The number of people that you can tax to pay the additional costs go down. So governments are in a box. I just went through the dilemmas. You can't take services away. You can try to restructure them, which is what everybody's trying to do. You can't easily raise taxes, especially on the next generation, of whom there are going to be fewer. When I tell graduate students at my university, as a way of getting their attention, because they're usually half asleep during my seminar, when I say, look, we're going to raise taxes on you to pay for my healthcare costs, that gets their attention fast. Because they come back and say, wait a minute, I've got student debt, fees are going up in Ontario at 5% a year, graduating into a very uncertain job market, university BA doesn't mean what it used to, you're telling me that we're going to have to pay higher taxes so that you can enjoy more healthcare? I say, yes, that's right. And that provokes an interesting discussion. We have always, in our country, from the very first moments of healthcare, thought about equity within a generation. And we've tried to achieve that equity principle by essentially raising taxes or borrowing money each year and buying a certain amount of healthcare services. And then we triage and we mortgage and we do all the things that we do with that money. That works okay as long as the demographic spread across the population age groups is about the same. But once you get a tilt like this, so there's more people over here demanding more healthcare services and fewer people over here that you can tax to pay, then the system begins to really begin to pinch. And that's what's coming. And that's why I think we should be looking at the notion of social insurance to pay some healthcare costs. Social insurance is like the pension plan. You pay in throughout your life. Governments make a contribution. Employers make a contribution. And at the end of a certain age group, you get a defined benefit from the government which you can count on. And you're willing to pay in throughout your life because you know you're going to get that benefit at the end of the day. So we know we're going to have more seniors. We know they're going to need more long-term care and home care. We know especially that they use pharmaceuticals extensively, that the average 70-year-old in Canada uses 6 drugs, and if you're over 80, more than that. And we know that outside hospitals and seniors, the drug coverage is a patchwork across the country. If you ask any provincial premier, doesn't matter what his or her stripe, Premier, what are your 5 big cost drivers, additional cost drivers going forward over the next 10, 15 years? Either they will know or their civil servants will have told them, it's the cost of my provincial drug plan. And how are we going to finance that? Well, we could delist some of the drugs. Good luck. Because the pressure is always to put more drugs on the formulary because medicine advances. We could increase the deductibles, especially on wealthier people, which is what they're doing in Ontario. That'll only get you so far. We could collectively buy drugs together as provinces. Of course they should do that. But ultimately, I think you're going to have, I think it would be good to have a social insurance model which the provinces could put together themselves, or from my point of view, the federal government should run, whereby there would be one buyer for drugs in the country. Look, I'm sorry, I'm a mania for comparisons, but we're the only country in the world that is stupid enough to have 11 formularies and 11 buyers. Now, Australia, our wonderful Australian cousins, have 6 states, and they have one buyer for their National Pharmaceutical Benefits Plan. We, because we're Canadians and think we have the best healthcare system in the world, have a completely perverse system for buying drugs. So we need to, in my view, have a national plan attached to the Canada Pension Plan. So we would all pay in throughout our lives for what is almost a universal need once you get to be 65 or 67 years of age. So aging, I think, is something that has many, many different implications. I've rattled on far too long, so I'll just stop and say, look, I could say lots about doctors, hospitals, and everything else, but I want you to have a chance to throw buns at me and so on and so forth. So let me just stop. As you can see, when I get started on this subject, it's hard to shut up, so I'll just stop.
Well, lots of ideas for our editorial program over the next year, Jeff. Thanks for that. Appreciate it. Q&As. By the way, more and more, every one of these sessions, we have clinicians. So this room is loaded with RNs and MDs. I'd ask them to put up their hands, but they may not want to identify themselves. Who's got the first question for Jeffrey?
Jeffrey John Abbott, the Health Council of Canada. Why are we so slow to learn from other countries?
Number one, to repeat myself, because we kept telling ourselves we had the best system in the world, and so we had nothing to learn from anybody else. Number two, whenever we look for a reference point, we look south, as we do in almost all areas. So both of those were huge inhibitors to having a kind of situational discussion of where we really are. And I think it's probably going to be that way. There's no other area of life that we pay attention to what's going on in detail in Europe or Australia or New Zealand or whatever. At the level of informed healthcare analysis, people know. But you know, John, for a long time, it used to just drive me to distraction. The academics who were in what I call the Romano school would spend a lot of their time at these conferences and in their writings debunking everybody else's system by way of sort of puffing up how good our system was. Now, it is true that every country is more or less unhappy with its healthcare system. And it's also true that there's no healthcare system that is close to perfection. But it's also true that there are a lot of systems that on the aggregate are better than ours. And that's the takeaway point. So can we learn from them? Can we at least get a starting point that says we can improve and should improve if we look at others? I hope the answer to that is yes.
My name's Andy Smith. I'm in an acute care hospital in a leadership role. So if we accept the premise, and I think, as you pointed out, we do accept the premise that we're starting to grapple with the myth not being true, and that we do, in fact, have a problem. We are on the burning platform. Now, I'm in the acute care hospital. I'm wondering, what is the enabler that needs to come from the highest level of government, whichever province it comes in, to really sort of make a cascade of changes happen at the rapid rate that one would hope could occur?
Well, thank you. There's a good question to which there's no simple answer, no brief answer, but I'll tick 3 points off quickly. One is to get the starting point right, okay? Secondly, to see that in the remedy proposed over a long period of time for what ailed our system, and it's still around with certain groups. Believe me, I've heard from them, and they're still very prominent, and they write op-eds, and they write letters to the editor, and they're very vigorous, is to have more top-down, more public administration, more public control. In other words, it's what I call the rational planner's school. Bring more into the tent. Classic example, since you're a surgeon, when it was in the newspaper some months ago that the Shouldice Clinic might be sold from one private owner to another, all working within the context of the Ontario system, paid for publicly, certain groups rushed into print and said, bring that into the public system, as if it isn't in the public system already. It is interesting that no country in the world has moved or proposes to move in that direction. They are all moving away from that model. They're all moving in their different ways, either to a parallel private system that I do not favor, or to more private delivery of publicly paid for services. That's what the world is tending to move towards. They either have a social insurance model system, or they have a competition set up between providers and payers and between different providers. So my answer to your question is, governments should, in a sense, free themselves and try to explain to the public that we're not abandoning Medicare. We're trying to achieve certain principles here with different modalities as the rest of the world are. We have a big hang-up about that in Canada, big-time hang-up that other countries have gotten over. Let me deal with acute care hospitals for a moment at a level of 33,000 feet, because the devil's always in the details. I don't understand why routine orthopedic surgeries are being done in expensive acute care hospitals, where they're fighting for OR time with very complicated surgeries in orthopedics and other disciplines. Other countries have moved these off into clinics where orthopods organize themselves privately, sign contracts with the government, and proceed if they meet 3 tests. 1, quality is maintained or enhanced. 2, access is enhanced. 3, cost is the same or preferably lower. You meet those tests, I'm not hung up that they have to be done, your standard knee and hip replacements, in an acute care hospital where people need neurosurgery or very complicated orthopedic surgeries. But we've got this kind of, and it's particularly acute in this province, I hasten to add. We've got this view that somehow that's contrary to the spirit of Medicare. We've got the longest wait times in the world. What are we holding on to here? What's the narrative telling us? Can't we be flexible and try other systems that will at least bring wait times and cost down? Last point. The state this is public administration, the state has a wide range of powers, from delivering things itself over to setting up crown corporations to deliver, like the post office, all the way over through various regulatory powers, heavy or light. So all of you have cell phones. All of us have all the fancy electronic goods. In a very light way, that's dealt with by the CRTC. They tell the cable companies whether they can or can't raise rates. They tell you who's got access to broadband, all that stuff. That's light regulation. In healthcare, we've pushed a whole lot of it way over into government, and government only has to deliver the service. And I'm saying all other countries have that as part of their system, but less than we do. And I'm just encouraging governments to kind of try to explain to the public that we're not abandoning the principles of equity of Medicare. We're looking for better ways of doing it. And it's perverse, in my view, to have as many things done in acute care hospitals as are being done. Partly it's not their fault. It's partly because there are no institutional abilities outside to do it. And it's partly because of this kind of ideological straitjacket we're in, that public medicine has to be delivered only by people who are paid agents of the state. No other country believes that.
Ian Mackay, Aramark Healthcare. Jeffrey, in that analysis, and you did mention some time ago that the knee-jerk reaction of most public and political people is to cite efficiency as the way through, and then you sort of left that and didn't. It almost sounded as if you were saying that's kind of a false premise, but I don't think you were saying that. But in your...
I'm saying that it is necessary but insufficient.
Okay. So in your analysis of the acute care segment particularly, what about the delivery of family practice, of primary care medicine? That seems to me to be the thing that is jamming up our ERs because people don't have doctors. Yeah. The incidence of clinics seems to be painfully slow in its rollout. And if you go to almost any European country, you will see that access to primary care is very much clinic-driven rather than driven by private practitioners. So
everything you've said is right. There's an old Irish joke, I think I quoted it in the book, which the guy's lost in Ireland, and he comes upon a farmer, he says, "How do I get to Ballygambima?" And the farmer says, "Well, I wouldn't start from here," right? So if you were designing the Canadian healthcare system from scratch and you knew then what you know now, you wouldn't design it this way. When it was designed, as you know, life expectancy was a good deal less than it is now. Therefore, the use of hospitals was a good deal less. Every town wanted a hospital for political reasons, and so there was a proliferation of hospitals, not just the big acute care ones, but much smaller ones all across the place. And Roy Romanow, to his great credit, when he was premier, closed a number of rural hospitals in Saskatchewan, which had been built over the decades to deal with the demographics of the province that was somewhat different. Okay. So ideally what you want is to have a family clinic literally associated with a hospital. And in Edmonton, they built, right across the street from their tremendous acute care University of Alberta complex, a very big, smashing, modern family clinic. Now, if those two work properly together, and I don't know that they are or they aren't, but the geographic propinquity suggests that if I show up at emergency and a triage nurse sees me and quickly ascertains that, I'm having a stroke, I go in the hospital. If she ascertains that I, have flu symptoms, she says, right across the street is the family clinic, please go there. So at the moment, and I'd love to talk more to ER docs about this, there is a disinclination to let the triage nurses, it seems to me, push people away from or direct people away from emergency, assuming that there are clinics available. Because they're afraid that if something ever happened, the hospital would get blamed, so the waits are enormous, and we're moving in the right direction towards clinics, multi-use clinics, with many different practitioners together. And I'm going to say something that will probably shock you in the august setting of Mount Sinai Hospital. I predict that in a decade, because it's already started, you're going to see family clinics at Walmarts and Costco's across the country, starting in the States. It's already here in Burlington, Ontario. I think it's going to happen more. Why? Because they already have pharmacists and opticians. They want more people to come to their stores to do their shopping. It's convenient because that's where a lot of people go to shop and spend their time. And so convenience and mutual, so I think you're going to see this kind of clinics. In Alberta, the minister, who's a terrific man, Fred Horn, is trying very hard, and he's in a headbutt with the Alberta physicians at the moment, to get the basic core of practice in Alberta being the family clinic to which every Albertan will be, with which every Albertan will be registered, which is the European model. Last point I'd make. In Sweden, which is a country for which I have a huge regard, and there's a section in my book about this. In Sweden, they had a total rethink of public administration about a decade or 12 years ago in the big cities. And they said that the model now for daycare, for education, for healthcare, and for pharmacies, because they all used to be run by the state, every institution within those 4 areas was run by the state. They said no. Now the state will set the overall policies, the state will register, and the state will monitor, but we are agnostic as to whether that education, that daycare, that family clinic, or that pharmacy is a private entity or a public one. And they believe that the money that they pay per student or per patient goes with that individual wherever he or she may wish to go. So, if you are registered with Family Clinic A that happens to be organized by a group of professionals privately, the ABZ Corporation, you are paid X amount of money to be rostered with that clinic, which will have pharmacists and so on and so forth. If you're not happy, you go across the street to Clinic B, which is public. A just lost money because I've taken the money that I have as a citizen over here. If you don't like B, you go to A. And they think in Sweden, and this is now universally almost, there's a little opposition, especially in the rural areas, they think this enjoins both to get better. And for a country with a long social democratic tradition, this is quite a revolution. Remember, the state's paying, the state's regulating, the state's monitoring, but the individual has the choice. So when the OECD analyzes our system and says that relative to other countries, we have the least amount of choice, that's kind of what they mean.
Anyone else? Jeff, I forgot to mention at the beginning that our next breakfast is actually the chair, the CEO, and the CIO of Cancer Care Ontario, taking a look at how they each deal with all the data that comes out and across their desk every single day. So that should be an interesting event.
Right.
Now,
well, thank you.
Sorry,
thank
go ahead.
for coming, and hope you all read my book.
So on that point, I've noticed a number of books in the audience, and they're still out there
Happy to sign them.
selling those, and he's happy to, in fact, sign them. In return, and under separate cover, I'm going to send you Ross Baker's edited book of the healthcare systems around the world. And we have our Dr. Ross Baker from U of T. I don't know if you know Ross. And then we have our own in-house pundit in healthcare across the country called Stephen Lewis. And he has written all kinds of essays, and we only have a few hard copies of an e-book.
Well, I've read a lot of what Stephen has had to write.
Have you? Well, you
should have the two of us here for debate.
It's a deal. Are we okay for that? Debate, Stephen Lewis? Yeah?
Stephen's a very bright man. He's a charter member of what I call the Romano School.
Yeah.
He was one of the folks, along with Morris Baer and Bob Evans, who recommended in the mid-'90s that we had too many doctors. And so we shrunk the number of physicians in medical school, and what any first-year economist could have known would happen did.
Well, I'll give you his essays just to warm you up a little on him, and we'll set it up. So your appreciation and thanks for Jeffrey Simpson.